And you're waiting. Here we go. There we go. Okay. So antibiotics are a little bit of a different topic than pretty much everything else we're going to approach this year. And the reason is because they apply to a lot of different systems. So infectious disease can affect pulmonary, cardiovascular, it can affect the circulatory system, it can affect pretty much anything you can think of, skin and soft tissue infections, hepatic, viruses, stuff like that. There's all types of different infectious diseases. So I think it's best to talk about them all as a group as opposed to bringing them up individually, because antibiotics also can use the same drug for multiple different types of diseases. So we approach antibiotics from the standpoint of coverage. So what does the drug cover? What type of bacteria is it active against? And then we look at what types of bacteria cause certain infections. So then we can match that up. Now there are certain things that we'll talk about too, such as some drugs don't get to certain areas of the body. There are some drugs that just don't get into the central nervous system. So for meningitis, we can't use certain drugs to treat that. But we have a pretty good arsenal out there, despite what the news tends to be a little doom and gloom, I think. And granted, there's some certainly problematic resistance out there, and we'll touch on that very briefly. But for the most part, we have a pretty big arsenal at our disposal. And yes, there's resistance to some bacteria out there, but we have a lot of things that we can use and a lot of tricks up our sleeve. So a little bit of background on antibiotics. So when I'm talking about an antibiotic is an antibacterial agent, and for the purpose of this lecture, we'll talk a little bit about antifungals and some other like protozoal agents and of course antivirals in upcoming lectures. But this is the bulk of the anti-infective agents we're going to talk about. And so there's pretty much a couple different mechanisms we're going to talk about, but most antibiotics fall into one of two. That would be cell wall inhibitors or protein synthesis inhibitors. And I'll define more of that as we get to the drug, but the idea is that you can work extracellularly on the cell wall or intracellularly. And you can combine the two mechanisms too. So if you have something that's opening up the cell wall, that might allow a different type of drug to get inside and work on the intracellular mechanisms easier, so you get some synergy approach there. Most antibiotics generally are very well tolerated. There's some with some side effects here or there, but most of the ones we're using now, with the exception of some allergic reactions, there's not a lot of side effects people get. Most of these drugs aren't long-term therapy. We're looking at maybe a week or two for the majority of cases. So you don't really get the chance to see what's somebody like on 3 years of a cephalosporin. We don't know because nobody takes cephalosporins for 3 years, or they shouldn't be. But for the most part, well tolerated. Resistance is of course a concern. We'll talk about some stewardship aspects here. And some tips for that, and how to be good stewards of our antibiotic resources. And most antibiotics are renally cleared. So I'll point out the ones that aren't, and those are worth remembering. But for the majority, by far and away, like 90% of them are renally cleared. So that's important when dosing medications, starting patients on antibiotics. Always make sure you understand the renal dosing, and when in doubt, look it up and make sure that you know. So there's a lot of ones to consider with that, but it's pretty easy as far as just remembering that the bulk of them are renally cleared, with the exceptions I'll give you. Resources. IDSA is the gold standard when it comes to infectious disease. It's Infectious Disease Society of America, and they publish guidelines periodically on everything, all major pretty much infectious disease topics. And they're the practice drivers in this country. Some of the stuff isn't up to date, so occasionally you'll see, well, there's a paper that came out in between guideline production, and we think, or maybe European guidelines were just updated to say this, and we think the IDSA guidelines are going to go for that when they come out next year. So you can take some of it with a grain of salt if it's kind of old and maybe there's more modern stuff out, but for the most part, it's pretty current. And again, it's how we practice pretty religiously almost with IDSA's recommendations. Sanford Guide, I talked about that briefly, and how it shows you spectrum of activity for different agents. So it's a handy guide. It's online. There's paper books that they sell that are really small. I think they're like $20 or something. Somebody told me there's a smartphone app. I've never actually tried to use it or mess with it, but I guess there is too. Maybe the newer books come with that, or you can buy it online perhaps, or in the App Store of some kind. CDC MDH has good references for pretty much everything, but specifically vaccine schedules and vaccine information. I'm not going to talk about vaccines during this block. We're going to talk about that specifically during pediatrics next summer. So I've got a whole section set aside for that, just because we get a little tight on time and it's more relevant in the pediatric patient population. Other things, Emergency Medicine Residents Association, or EMRA, publishes this little pocket book that has infectious disease pearls and quick dosing handbook type of information in it. Johns Hopkins publishes a big antibiotic guide. It's sort of a pocket book, but it's really thick. I wouldn't carry it in my pocket personally, but it is a pretty comprehensive book too. So these are just things people like to use. If you use any good drug monograph or database, you're probably going to get the similar information. It's not like one of these has information that another one doesn't, with probably the exception of Sanford being the only guide out there that really has a pretty good comprehensive table on what drugs cover what microbes, and that's really handy, and it's unique to that source. Clinical specialists are, of course, handy. If you ever have a patient, we have PAs, and I think maybe an NP, that work with our ID providers, so you could certainly go into that as a career. But if you don't, and you're working in general medicine, feel free to refer people to those providers, contact them for consults. That's what they're there for. They have a lot of insight, and it's nice to work with them from a pharmacist perspective. We also have pharmacists that specialize in infectious disease training as well, so they do an additional year of residency training, specifically focused mostly on stewardship, so being a good use of our antibiotics and making sure we're appropriately discontinuing therapy, de-escalating, using the right drug for the right time, more so than actually like the clinical decision making, but certainly have that expertise as well. So the mean inhibitory concentration is a term you might hear thrown around when it comes to antibiotics, and there's a couple things that I'm going to show you in a picture here, and I'll explain it, I think, a little bit better there. But it's basically the concentration you need to achieve with the antibiotic to kill the bacteria. And then labs will generate a cutoff of some sort. This could vary depending on the lab and depending on the assay they're using to test. So cutoffs won't be universal, but what the cutoff is going to do is it's just an assigned number. So if you're testing for sensitivities on a specific organism you've isolated, it'll come back and it'll say, well, I guess I'll just go to that slide. It's easier to point this out. So, for example, here, you've got a urine culture. It's growing E. coli, and let's look at ampicillin here. It says it's resistant, and here's the MIC. So whatever this lab has decided was resistant was above, that MIC is above their resistance cutoff. And likewise, S means susceptible. So if it's below 1 or below 4, that means that it's met the cutoff for the mean inhibitory concentration, which is appropriate for that specific drug to be able to kill enough bacteria to be effective. And so that's all done based on lab culture growth and how it responds to certain discs that are inoculated with the antibiotic and how that kills, how many bacteria that kills within a certain radius. So that's all microbiology that I'm not an expert in by any means, but that's the gist of it. What you'll see at different institutions is possibly different sets of assays. So where this is Alina's standard one for urine cultures, it's going to look different for blood cultures. It's going to look a little different for wound cultures. The reason is we don't use all the same agents. So like nitrofurantoin or macrobid is only a urinary agent. You wouldn't want that on a wound culture because it makes no sense to ever use that medication. So they are tailored that way a little bit. And if you go from one institution to another, they might have a different set of medications. So, for example, we have imipenem. That's our formulary carbapenem, whereas another hospital might have a different one, and it might have that on there too. So it's just going to depend system to system. There might be some differences, but they should have pretty much a general variety of things, from more basic drugs like ampicillin, various generations of cephalosporins, and then some other things too that we'll get into. So this is the basics behind how to read a culture, and we'll come back to that a couple times throughout the course. So don't worry too much about it right now. We'll get into some of our details in a second. Yeah.
Can you define cutoff?
Cutoff's just what the lab says is sensitive or not. So it's a number that they've assigned based on the MIC. So they'll calculate an MIC based on how much bacteria the drug disc is killing, based on what kind of radius they're looking at in a petri dish, and then they can look at whatever they've assigned the cutoff number to. So if that number comes back as an MIC of 4, the cefazolin, well, that might be right on the borders. They might say that's intermediate sensitivity. That's where they're cutoff. Or maybe it's 20. That's above 4, and maybe 4 is their cutoff. Well, that means it's resistant. So.
You mean the cutoff, like the minimum amount of drug that needs to be given?
It's for susceptibility versus resistance. So minimum inhibitory concentration is a number, and labs will assign a specific cutoff that number has to meet in order to be sensitive. So that
So can you go back to that when it says like less than 4?
Yep.
That means what? how much drug you have to give?
Nope. So that's just saying it's sensitive or resistant.
So it's the same as a therapeutic index.
Not really. It's kind of a similar concept, but not quite, because we're not really talking about safety profile here. We're simply talking about the amount of drug needed to kill it. So if this number is really high, they're going to put a resistant flag on it, so that they're going to say that we looked at this in lab and this drug is not killing this bacteria. Don't use it. That's really all this is saying. Susceptible, resistant, intermediate's a crossroads where some cases you might be able to use it, other cases you might not be able to. Generally speaking, we don't use intermediate drugs because you're just unless we have no other choice. So don't get too caught up on the numbers. That's the MIC, and like I said, the MIC it can vary a lot drug to drug. So I've had providers say, well, this one says it's less than 1. Where's my cursor? This one says less than 1, but this one says less than 4. So less than 1 might be better. That's not true. It just has to do with where the labs assign those cutoffs and what the published literature says you need to have for a certain cutoff for certain drugs. And cutoff and MIC are really the same thing. And a cutoff is just an assigned MIC that the lab's using to determine whether it's sensitive or resistant.
And is that based on the medication?
Yes.
Specifically,
Specifically, yes. Yep. So the medications will be different, and then, of course, it depends on how it responds in the lab to the specific bacteria that's growing. All right, bactericidal versus bacteriostatic. Bactericidal is a more common form of antibiotics. It's a faster killer. It's concentration dependent or time dependent. So you have two different subtypes of it. Concentration dependent just means that you have to get really high concentrations of a drug in order to kill the bacteria. So it basically, you give a big bolus of drug and then you get a really long effect from it. It's sort of the theory behind concentration dependent killing. Time dependent means you just need to be slightly above that MIC, so they think 2 to 4 times what that MIC came back at, and you're going to get a killing rate. Now, we don't actually have to think too hard about this. Most drugs are time dependent, so the dosing's all pretty much done for you. Like if you look up dosing of a time dependent bactericidal agent, you're going to see that it says give it 500 milligrams 3 times a day. You don't have to measure MICs or anything on those drugs. That's what the clinical studies did and what they proved to be effective for those medications. This is just some of the theory behind how we dose antibiotics. So the point is that with concentration-dependent killers, which there aren't a lot of them out there, I'll mention one big class is aminoglycosides, which we'll talk about in a few slides here. But when you're targeting really huge concentrations right off the bat, you end up with increased chance for side effects because you're increasing the blood concentration so high. So we've moved away a lot from concentration-dependent killers because of those issues. Every once in a while we need to bring them out, but for the most part they've kind of fallen by the wayside. And part of that is because of the toxicity risk with targeting those huge concentrations above your MIC right off the bat. Yeah.
What's the difference between like giving a big dose that would detect over a long period of time and like just giving it at different times? Why would it be better?
So it's all about getting to steady state and preventing side effects, and you also want to kill the bacteria with the least amount of drug possible to prevent side effects, but you also don't want to breed resistance either. So that's where the studies have said that 2 to 4 times MIC is ideal for a concentration-dependent killer. So it's sort of like we talked about last week, where you have steady state, where you give a drug, get a peak effect, it starts to get eliminated. Give another dose here, or maybe it's probably a bad idea. So that can get eliminated, and then you give another dose. Eventually, it kind of evens out. So this would be more like maybe your MIC is here, so maybe it's like a 2. We'll just make up a number. What you could do with a concentration-dependent killer is give a really big dose, you get a massive peak. Now, generally in healthy people, the body is going to eliminate. Sure, it's going to stick around the body a little bit longer because there's more of it, but it's still going to cut out pretty quickly, and eventually it's going to catch up to that curve. So you don't get that much more activity off of it. So there are some drugs that can be formulated to have more of a delayed onset and a delayed release effect, but that's not what we're talking about here. So what you end up doing with this is, you have your back to your therapeutic index comment. You have let's say you have a cutoff for side effects up here, which is your toxic 50%, TD 50, and so you're crossing that. So what's your risk there? the idea is that with this you get a bigger area under the curve overall. So you have time above MIC. So this is your MIC concentration. This is where your blood concentration wants to be. You don't really want these troughs dipping below this. Every time it dips below, that means that there's a possibility that you have too little drug in the system. That's a possibility for resistance at that point. So when it comes to dosing antibiotics, we're looking at how much is within this range here. And so we can calculate that and do nifty kinetics and stuff like that. But really, with a lot of the drugs we're using today, we don't even have to think about it because they're mostly time-dependent killers, and we're just dosing them based on the studies that have been done and what's been proven to work in those situations. There are a couple drugs we do blood concentrations on, and we dose adjust based on kidney function and things like that, of course, but we'll talk about those specific instances. But for the most part, everything you can pretty much just, as long as you're dosing it appropriately for their kidney function, you can let most things ride based on how they're published, what the published literature says to do. So, I know it's kind of a complicated scenario. It's really I don't think it's a key concept to being an effective infectious disease prescriber, but it is something I think worth understanding. So let's talk about some drugs, and we'll come back to some of these concepts as we go through. And if things still don't make sense, we can revisit some of this stuff. Bacteriostatic is slower killing. It's what it does is it prevents bacteria from growing, so eventually the bacteria just dies off. It does work effectively. There are some drugs that work this way, but it does take a little bit longer. So sometimes when they're in between a slow-killing agent or a bacteriostatic agent versus a bactericidal agent that's faster killing, most ID providers would say, let's pick the bactericidal agent because it's going to get your bacteria destroyed a little bit faster than the other ones. There's not many bacteriostatic agents that we use in regular practice, but I'll talk about a couple of the key ones. Post-antibiotic effect is a theory that I'm not going to get into too much, but suffice to say, sometimes after you dose a medication and it completely leaves your body, or mostly leaves the body, you end up with some time after that where the bacteria is just not growing. Basically, you killed everything that was around except for maybe some things, and they just aren't going. It's going to take a long time for that regrowth to happen. And it's really no point in redosing the antibiotic aggressively. So some things, and I'll talk about some of the drugs we do that with, but it's really not all that important. There's pretty much one drug class that follows that, and that's aminoglycosides again. So it sort of goes hand in hand with concentration dependent killing. You're getting big doses and you're getting that post-antibiotic effect from that. So, and aminoglycosides pretty much are the only ones that we care about that do that nowadays. There's a couple others, but those are the big ones. All right.
I have one question on that.
Yeah.
What did the focus on be?
So area under the curve.
Oh, okay.
You just really want sort of the same amount of area under the curve. And the idea is with a big peak and a steep drop off, you still get a decent amount of area under the curve above the MIC where you want it to be. Versus this would be smaller peaks over time, but overall you would have a decent amount of area under the curve too. And that's just showing you how much above you are in the MIC, where your peak is, and you could do a calculate. Like if you wanted to do a model to see which one was more effective, if you're doing research on dosing, you could calculate area under the curve using whatever type of math you do that with. It's been a while, calculus maybe, and then figure that out based on how much area under the curve there would be and which one would have more, and then you could think about, well, are they comparable if we dose it once daily or twice daily? That's sometimes how they get to that. For our purposes, it's not really all that important. Okay, a little blurb about resistance and stewardship. So I said that there's a lot of doom and gloom in the news, and every once in a while you hear about these superbugs wherever. I don't think we've had any real cases in Minnesota that have aroused from Minnesota. We've had maybe some people come in who've gotten infected somewhere else. That's what we're seeing mostly in the United States. There's a really big problem in India, which is probably the biggest outbreak of some Carbapenems producing strains of gram-negative bacteria. And we'll talk about Carbapenems, but Carbapenems are our last line for gram-negative infections. So once we have something that, pretty much our last line. Once we have something that produces an enzyme that can break that drug down, that's developed that ability, then we're in big trouble because it's difficult to kill that bacteria. We have some older drugs we can go to, but they're very challenging to use. They're toxic. They aren't fun, and we don't have a lot of data to support using them yet. So when it comes to resistance, we're seeing some shifting across the globe of some of these strains, but this is where it becomes really important. not only to be mindful of how you're prescribing antibiotics, but knowing your local resistance patterns. I think I have a screenshot up here of an antibiogram. Yep, it's on the next slide, so we'll get to that. I'll show you what that means. That's hospitals publish something called an antibiogram. Minnesota Department of Health publishes an antibiogram. What it's showing you is common pathogens in the area, and based on reports that it's getting, what type of resistance patterns we're seeing locally. So it'll tell you, strep pneumo for pneumonia, and what antibiotics are working for it and what aren't. And I'll show you an example of that here in a second. Don't use anything you don't think you have to. So it's a kind of an obvious one, but it's really important because I think people overprescribe antibiotics, and I think that there's a lot of patients out there that push antibiotics and want antibiotics. So they call, like, our ED is in Minneapolis, but we support an ED, a satellite ED in Plymouth at West Health, and they say, well, we've got drug seekers in Minneapolis and we've got antibiotic seekers in Plymouth. That's kind of a joke that providers like to say. So it's like people come in and they're like, no, my kid is sick or I'm sick, I need a Z-Pack. I'm like, no, you don't. You don't need that Z-Pack. Let's think about this before we prescribe this. So getting good on talking people down is going to be a good skill to have, especially if you work urgent care. Very good skill, or primary care, I think. Broad spectrum doesn't always equal better outcomes. There's certain times where we just like to really go broad because we don't know what we're treating. It's a serious infection. We want to throw the kitchen sink at the person and we'll adjust later. And that's common practice. That doesn't mean that you're going to improve outcomes in your patients. Some points to consider. So patient history. Always think about previous cultures and exposure. So where have they been? What's been done recently? What antibiotics have they been on? That can really tailor your therapies. If they just came in and they failed a course of something, you want to know that. And that's not always apparent in your electronic medical record. They might be in a nursing home with paper charting that you may or may not have access to. So getting the history is really important. Length of treatment. Are you treating for the correct length, and did they take a previous medication for the correct length of time? Have they been adherent with their regimen? Those are things to think about too. Allergies are always something that comes up. Probably the biggest issue that I experience with allergies in electronic medical record system is somebody comes into the hospital and says, I'm allergic to penicillin, and I got nauseous when I took it, or it made my throat tickle. Okay, what does that mean exactly? So those aren't real allergies, and if you need to give somebody a life-saving medication because of that, that can be a big deal, because as a provider, you'll see a big flag on the chart that says this person's allergic to penicillin, and you're trying to prescribe something in the penicillin family. What do you do with that? Well, first, you want to look at the reaction and say, what was it? Was it an actual allergy? Then we get really concerned about actual anaphylaxis and hives. Those are considered type 1 hypersensitivity. Beyond that, like a rash, if it's a serious infection, we don't really care about a rash. If they got nauseous on it, again, if serious infection, we don't really care about that. You can mitigate some of those things, but with either antihistamines for the rash, you can give it with food for the nausea and vomiting. But the point is that allergies sometimes are really bogus, so double check your allergies. And those childhood reactions, studies have shown that most people that report those, like only 1% of people will actually cross-react to the medication they claim to be allergic to from a childhood. So it's really low. We'll talk about cross-reactivity here in a second. But just allergies should be taken seriously, so I don't want to totally downplay them. But always double check your allergies before you decide to totally alter your treatment plan to something odd because you think there's an allergy, when in actuality, a lot of times I've gotten calls and been like, I really want to give this person this drug. They're allergic to these things. What can I do? And it's like, well, they aren't actually allergic to this, so let's try this. And I looked at their chart. They've tolerated it in the past. So that's another thing you can do if you have access to previous medical records, is check that. So there's just some tips for things to consider. We'll talk about some drugs and classes, but following general guidelines about prescribing appropriately, narrowing therapy is going to be a big thing we're going to talk about here too, when appropriate. And that's basically all you have to do as a prescriber to be appropriate in your stewardship, from the stewardship aspect of prescribing antibiotics. If you're not thinking about it, prescribing willy-nilly, that's where we get into trouble. And the more classes of drugs we lose, we could end up in a situation like India where they have a big epidemic of this specific bacteria that's causing huge problems for them that they can't treat. So this is all to prevent that, hopefully. And this is an example of an antibiogram. So this is our hospitals one. And again, all hospitals have these. They usually publish them once a year. Microlab does it. So every time you get a culture back, the microlab will keep that as a data point, and then they'll compile it all at the end of the year. So it's interesting to see the resistance patterns over time. But let's see if there's a fun example I can pull off of this one. This one's kind of old, but let's see. So here's E. coli. How many of you guys have heard of Bactrim? What do you think about when you think of Bactrim? Like for infection wise.
It's supposed to work.
For what? UTI, yeah. It's 80% susceptible for E. coli. So that's 1 out of 5 patients you give it to will have to come back for a new antibiotic. So that's why the importance of this. People think that some of these drugs work because they did in the past, and they have, but it's really important to double check what you're working with locally. You might go to an area of the country where Bactrim has great, maybe 90 plus. But here, 80 is actually high. We're more in the 70s now with the current data we have. So it's going down. So that's just an example. But we'll talk about some of that resistance stuff when we talk about the treatment plans in the recording next week. All right. So questions on any of the background stuff before I start talking about the drugs specifically? When we talk about the drugs, we're going to talk about them in terms of class and in terms of spectrum of activity. And then the next series of slides goes through different specific infections and what would be maybe considered first line, second line alternatives for those infections. So beta-lactams are a broad group of antibiotics. So you have everything from basic penicillin to really advanced super broad spectrum drugs like carbapenems. And they're all technically within the same class. They all break down a little bit differently. So you basically have 3 different groups: penicillins, cephalosporins, and carbapenems. There's also something called monobactams. There's only one monobactam on the market, so it's more like a monobactam. There's no plural there. But this is how they break down. They're all sort of related. They all work by breaking down bacterial cell walls. So their mechanisms are all pretty much the same. It's just the different functional groups and structures that allow them to be more resilient to bacterial defense mechanisms. And they might bind to different subtypes on the bacterial cell wall, too, that makes them less likely to more likely to break down the bacterial cell wall, and less likely to get broken down. A lot of bacteria have developed penicillinases, cephalosporinases, and now even we're starting to see carbapenemases. And when I put an ace on the end of anything, that's an enzyme. So when bacteria produce any type of enzyme to break that down, that's a problem. So we've been formulating some of our antibiotics with certain beta-lactamase inhibitor medications. So we'll see something like amoxicillin by itself doesn't have a beta-lactamase inhibitor associated with it. Amoxicillin plus clavulanate or augmentin does. Clavulanic acid inhibits the ability of the bacteria's beta-lactamase enzyme from breaking down the amoxicillin molecule. It doesn't have any real additional antimicrobial activity, but by doing that, it extends the spectrum and allows that drug to be a lot more effective. So again, these drugs are pretty much as old as they get and as new as they get. They're all bactericidal. We talked about this. They're all time-dependent killers. All the dosing is very standardized for these. Let's see. Lots of benefits with using these. They really have very few drug interactions. They're mostly universally safe to use in pregnant patients and children with a few exceptions. So very good drugs to use as an entire group. So this includes cephalosporins, carbapenems, and penicillins. There's a few things we're going to talk about specifically as far as side effects goes. They're very well tolerated overall, and that's why we like these drugs a lot for our core regimens. Often, all the time, they're going to have a beta-lactam component. The one area of weakness I would say is most of them, with the exception of maybe a couple, are dosed 2 to 4 times daily. So sometimes if you're discharging somebody on like cephalexin, which is the first generation cephalosporin, it's a 4 times a day dose for most indications. So not the most convenient, but you know they do work and they are well tolerated. So we are okay with that for the most part. Measure the term penicillin binding protein, which is a mechanism of cell wall production for bacteria. So bacteria use this protein that is called penicillin binding protein, because that's where penicillin binds to. But it's actually the protein that helps build the cell wall and helps synthesize the cell wall for various bacteria. So there's a spot on that binding protein that they've drawn in here with a B for beta-lactam, where the beta-lactam binds to. And when you bind up that specific spot, it can no longer continue the chain that produces that cell wall. So the bacteria dies, can't complete its cell wall, and it will continue doing that for a number of other bacteria. The other way you can do it is by actually binding to the cell wall component itself. And so this is a drug called vancomycin, which is not a beta-lactam, but it's a cell wall destroying agent similar to similar to our beta-lactams. It just works on the opposite side of things. So you end up with it on that, not touching the penicillin binding protein at all, but it still accomplishes pretty much the same goal. And by doing that, it has a bit different spectrum of activity and can be a little bit more flexible with certain bacteria. You can give the two together and get synergy. So if you block the penicillin binding protein from one end and block the cell wall component on the other side, you can end up with two mechanisms of action that work together that way. So there's ways you can combine these two. Generally speaking, we've never combined two beta-lactams of the same class, of any same class. You wouldn't combine like a cephalosporin and a carbapenem. There's no purpose. They have the same mechanism. You pick one and then you pick a different class. So from the purposes of infectious disease, all beta-lactams are kind of one group for treating patients. You don't want to mix them up. But they all have very different uses within their different categories. Again, very well tolerated. Any antibiotic is pretty much going to cause some sort of diarrhea. It's kind of unavoidable. All antibiotics will kill some type of GI flora, and in that case, you're going to get some kind of imbalance there, which is going to cause diarrhea. You take a probiotic, probably not a guarantee that it's going to do anything. They've studied it. It doesn't show any evidence in clinical trials that it actually does anything. But if it makes your patient feel better, go for it. Diarrhea, pseudomembranous colitis is the worst thing that can happen, probably from a side effect point of view, and C. difficile colitis too, which is an overgrowth of Clostridium difficile, which we'll talk about, which is a really big, as far as benchmarks go in hospital-acquired infections, it's a big thing that we target prevention of in the hospital setting, because if people get it, they stay in the hospital for more days, it's more money, bad outcomes, and it's terrible for the patients. So it's usually treatable, it's just not ideal to have diarrhea 20 times a day. Drugs in this class with any type of beta-lactamase inhibitor are going to be naturally more likely to kill off bacteria in the GI tract, and therefore they're going to be more likely to cause GI symptoms like diarrhea, and probably have slightly higher risk for causing things like C. difficile. It's not a reason not to use them, but it's just something to prep your patient for. Diet, like taking them with food, might help with that, but it's not a guarantee. If you take a lot of beta-lactam, or you have a patient with bad kidney function and they've taken a lot of beta-lactam and it's accumulated, central nervous system effects are the biggest issue with these. So seizures, coma, movement type disorders like myoclonus and hyperreflexia are things that you could see. I don't know if I've ever heard of this happening from one of our patients at the hospital. I know sometimes if somebody has an epilepsy history, you might be a little bit careful with the dosing of certain agents, but for the most part, this is really rare, and you'd have to get a ton of it into the person. So it's unusual to see, but it is worth saying that you might think, well, if these are so great, why do we even bother about dose adjusting them in renal dysfunction? Well, because theoretically there is some risk here. Pregnancy and lactation, again, most of them are great for this. And allergic reactions being the big thing that I have a couple slides on specifically. So you see a lot of patients, pretty much everyone, it seems like, well, not everyone, I should say maybe like, 1 out of 5 patients comes into the hospital has some sort of a beta-lactam allergy of some kind. Maybe not allergy, it's some sort of intolerance. They're so common, so people take them and they get whatever side effect. So then it goes on their chart forever. Anyway, I'm going to stop ranting right now. Penicillin. So basic penicillin is still a very useful drug today for very specific things. So we don't use it a lot, but it does still have its niches out there. It comes in 2 different forms, penicillin G and penicillin VK. I don't care that you know the 2 G versus VK, but if you're prescribing it and you see those differences, G is the IV or IM product, and VK is the oral product or the tablet or suspension. Mostly penicillins are going to cover gram-positive bacteria, so streptococcus is probably the biggest one. So like when you think about strep throat, penicillin's the primary choice for that. So we're covering group-based strep. Covers most different types of streps. It also covers different meningococcal species as well. So penicillin can still be quite useful for certain infections, including like central nervous system infections if it's sensitive to penicillin, because penicillin gets into the central nervous system at really high concentrations, which not all bacteria or not all antibiotics can do. Most gram-negative bacteria have intrinsically resistant mechanisms to penicillin, so they just will have a built-in beta-lactamase that will eat up the penicillin. It doesn't really touch them. So penicillin, useful, but only in certain situations. Anti-staphylococcal penicillins came later, and there's a couple on here. The only thing to remember about these is they're really narrow spectrum. They're expensive. Well, the only thing, I'm listing like 4 things. There's a couple things to remember, okay? But basically, you would, from a clinical treatment strategy, methicillin susceptible Staph aureus is the only time you use these medications. You don't treat empirically for these, meaning, like if somebody comes in with a cellulitis and you think, oh, I want to use an anti-staph penicillin because I think it's a staph-related infection, you wouldn't start with one of these agents. You're always going to wait for your cultures to come back before you narrow to it. Lots of problems with them. The multiple times a day dose, really expensive. They aren't very used very commonly, so drug companies charge a lot for them. And then they don't really cover much other than MSSA. So unless you know for sure that's what you're dealing with, you don't want to try anything else. They don't cover strep species all that well. They're pretty much a silver bullet. And I just put on there that nafcillin, which because it's kind of would be something that people like to narrow to. So like if you have somebody who comes in and there's a bad skin soft tissue infection and they're narrowing therapy because it comes back and says, oh, it's methicillin susceptible Staph aureus, let's put them on nafcillin. Nafcillin's a really strong CYP3A4 inducer, so it's going to rev up your liver enzymes. So big drug interaction potential there. Yeah.
What is MSSA? I know MRSA.
So it's the opposite of MRSA. So it's methicillin susceptible Staph aureus versus methicillin resistant Staph aureus. So that's the cutoff with Staph aureus drugs or Staph aureus, where we can use a group of drugs to treat MSSA and a group of drugs to treat MRSA. And I'm going to point you out which one specifically treat MRSA. MRSA is associated with, well, historically was associated with healthcare exposure and immunocompromised patients, but now we're seeing a lot of community MRSA too, and it's pretty common. So I wouldn't say, I mean, we do a lot of follow-up through the ER for patients who get discharged with cultures who might come in with like a cellulitis or a UTI, and then we follow up on them. And the number of people I've talked to are like, how did I get MRSA? Like, I couldn't tell you that. You came in contact with something that had it, or a family member might have gotten it. It's difficult to say. Some people are colonized with it. It's hard to say who would be or who wouldn't be. Yeah.
I'm not understanding. If it's susceptible to methicillin, why do you use something else?
So methicillin doesn't really exist. So it's a term we use. So methicillin isn't. Maybe you can get methicillin still, but I think it's an old drug. And it was something they used originally to define the term.
So it was susceptible to it, but the drug doesn't exist.
Methicillin was an old anti-staphylococcal penicillin, so it doesn't really matter anymore from a drug perspective. So you won't ever see, the other thing, you won't ever see methicillin pop up on a culture report. You'll see one of these drugs, like oxacillin or nafcillin. So that's your trigger. First-generation cephalosporins also are a trigger. If it's sensitive to a first-generation cephalosporin, it's not MRSA, it's MSSA. So that's another one we use. And that's the more common drug we'll use that we'll get to in a second. But these ones, again, really have a niche, and they're only for the methicillin susceptible Staph aureus.
Do you know for the drug interactions on do you just type it into that little app to see the interaction, or do you actually know?
It depends. A good electronic medical record system, or when you're prescribing something, will flag you if there's a significant drug interaction, and will tell you. Not that you should rely on that, but I would use like some sort of an application that has that too, where you can cross-check all that stuff. I know a lot of them off the top of my head, but there's still some that I'm like, well, everything's metabolized by 3A4, it seems like. So that's a no-go for a lot of things.
So what's the significance of that being a strong CYP3A4 inducer?
So it's going to induce your enzyme production in the liver, which means that you're going to metabolize other drugs that are metabolized by CYP3A4 much faster. So anything that's CYP3A4 metabolized, which is like 50% of the drugs on the market, will get through the body faster. Generally speaking, clinically, it's not relevant for a lot of things, but there are some where it could be devastating, like transplant medications or things like that. Something we just watch out for. Extended spectrum penicillin. Yeah.
So is MRSA resistant to all these other drugs?
I will give you very specific drugs that work for MRSA. Yep. So I haven't given it, and then I'll summarize after each section, so you'll get all that. If you have any questions on it at the end, let me know for sure. But it should be pretty clear. But your question is no. None of these work for MRSA yet. So extended spectrum, we're coming to amoxicillin and ampicillin. Basically, amoxicillin and ampicillin are interchangeable. One's PO and one's IV, as highlighted on the slide there. And then we combine them with beta-lactamase inhibitors to make them have a higher spectrum of activity, broader spectrum of activity. So amoxicillin and clavulanate, or ampicillin and sulbactam, essentially the same thing. One's augmentin, one's unison. They have pretty good general coverage against basic gram-positive and gram-negative agents. And whenever you add a beta-lactamase inhibitor to a medication, specifically beta-lactam, beta-lactam, but any type of any drug within these classes. So whenever we're combining these, you're going to get anaerobic coverage. So anaerobic coverage is important specifically for intra-abdominal infections and any type you're looking at GI-related pathogens. That's primary anaerobe territory, and that's going to be what you're going to want to target. In addition to gram-negatives, there's lots of gram-negatives in your gut too. But if you have like a perfed appendix or something like that, that's going to require anaerobic coverage. And we'll talk about that during the next set of slides and where exactly we treat people or what we prefer to treat people with intra-abdominal infections. But the point is that these specific drugs, when you add that beta-lactamase inhibitor, they gain anaerobic coverage, whereas by themselves they would not cover anaerobes. Yeah.
So for test purposes, do we focus on both of the names?
I will not give you any brand names on tests for your course policy.
And so that's the one in.
That's the one in parentheses. Yep. Usually the ones that have a more catchier sounding name to them, shorter. Although I do like to use them because, for example, piperacillin tazobactam kind of has a lot to say. Zocin's a lot easier. So anyway, piperacillin tazobactam and ticarcillin clavulanate are two really broad spectrum, extended spectrum penicillins. And basically, it's kind of like what we were talking about above, except a lot bigger coverage range. And these are, especially ticarcillin clavulanate, we don't use all that much. I think it's a little bit weaker than Zocin. Zocin's a huge workhorse in probably any hospital you're going to go to in America. It's one of our primary broad-spectrum agents for empiric therapy for anything from pneumonia to sepsis to whatever it might be. If we don't know what we're treating and the person's critically ill, they're probably going to get Zocin. It's a nice drug because it covers a huge range of stuff, but it also has that anaerobic coverage too. So if you have somebody with a severe intra-abdominal infection coming in, they're septic, it's a good medication to start with. What you want to think about with Zocin also is that it doesn't have any good CNS penetration, so you can't use it for central nervous system infections, which don't come up that much. And these two medications are IV only. So whereas amoxicillin and augmentin are PO, these two are only okay IV. There's no oral equivalent. So if you're giving somebody Zocin in the hospital, discharge them. What are you going to discharge them on? Well, you can't really do that. So you have to think about that in advance. Again, most beta-lactams are dosed multiple times a day. Zocin was traditionally dosed every 6 hours, and now we're seeing a new dosing strategy. So because beta-lactams are time-dependent killers, we used to dose them like 4 times a day. Now they're doing something called extended infusion, so like if you just give a regular infusion over 30 minutes, IV, you're going to ramp up your drug, and then it's going to get in and get out, and then you give another one. If you extend the infusion over 4 hours, you're basically getting a really slow onset, and then it's going to take a long time for it to get out too, because it's still infusing over that period. And you're going to continue doing that. And the point is that we don't really care about these high peaks. That doesn't matter with this type of a drug. What we want to do is get above this MIC line. So again, as long as your trough levels aren't dropping below that line, it doesn't really matter how high you get. You just want to be in that range. And so that's where they've tried these new strategies to get more of this, almost a continuous rate. It's almost like a continuous drip of Zocin in a way, where they're getting pretty steady levels throughout the entire infusion. And it also helps with the initial dosing, which would take a few doses to get to steady state. You can give a loading dose, and then start this extended infusion to get them up a little bit higher faster and give them pretty much a continuous rate of drug. They found that they actually get lower resistance rates overall with that. So like our system adopted doing this a while ago, and I think it's become pretty standard for most places. So if you ever see that, like why are they infusing this over 4 hours, or your nurse calls you and says, I got a line tied up because of the Zocin, what should I do, or where should I, could I get another line in, or can I get another IV order, or something like that. That's because they do this sometimes, where it's pretty much continuously infusing for most of the day.
Did you call it something special when you had the initial?
A loading dose, or sometimes they call it bolus, sometimes they call it loading, but we call it a loading dose. So you might give so like for Zocin example, a loading dose is 4.5 grams one time, and you give that over a fairly fast period of time, and then once that's done, you might wait. I think we wait 6 hours, and then we start the the infusion over 4 hours at that point. So it helps get the level up a little bit higher faster, so that you're catching this on the downtrend of it. You're catching it a little higher than you would if you were to wait all the way and then do another dose. It's more steady and more consistent is really all it is.
Did you say that Temectin is weaker than Zosyn?
A little bit. Its coverage is not quite as good. Yep. So most places use Zosyn that I've heard of or been to. But a lot of this can depend on cost and formulary acquisition too for the hospital. So if they have a really great deal for Temectin, they might use that product. But most places are going to use Zosyn. Okay, cephalosporins, there's multiple generations of these, which makes them kind of confusing, but when we talk about the actual treatment, I think they make a little bit more sense. But first through fourth, technically there's maybe a 5th generation cephalosporin that's coming out, but that's not really relevant because it doesn't exist yet. Similar side effect profile to other beta-lactams, so these are well tolerated, and pretty much the higher the generation, the broader the spectrum, and the more gram-negative stuff they're going to cover. So like a 1st generation, we're looking at very limited gram-negative bacteria coverage and some most standard gram-positive. And the higher generations, you get just extended coverage. So it pretty much follows a trend that way, but there are some caveats here and there. Sometimes you might see a bacteria resistant, like on a culture report, to a 1st generation cephalosporin. That doesn't mean that they can't be used for higher generation cephalosporins. So don't think about them. Think about them as sort of on their own islands within the generations. And always do your double checking to make sure that you're cross-referencing that way. I've had people say, well, it's sensitive. I've had it the opposite too, where I've had a provider say, well, this is sensitive to a 1st generation cephalosporin, so I'm going to prescribe it. Or this is sensitive to a high generation cephalosporin, so I'm going to prescribe a 1st generation. No, you can't really go backwards or forwards. You have to look at your sensitivities and make sure it's sensitive to all generations if you're going to go down or up on them. That's really important with these. So again, think of them as separate as far as the generations and what they cover. But there is a lot of similarities and crossover as well. Names are really tricky with cephalosporins. They're spelled weird too, like CEF, CEPH, prefixes. There's no real standard, which is really helpful for everybody. All right, 1st generations are cephalexin and cefazolin. So cephalexin is Keflex, cefazolin is Ancef. They pretty much have interchangeable coverage. Some people would debate that, but we use them interchangeably in clinical practice. They have really good MSSA and streptococcus coverage. So for skin and soft tissue infections that aren't caused by MRSA, this is your gold standard medication here. We love these. This is going to be every pre-surgical patient who doesn't have an allergy or a history of resistant pathogen is going to get cefazolin IV before the incision. That's a gold. It's not even a gold standard. It's a benchmark that hospitals have to meet. They have to give antibiotics before incisions. So this one is going to be any place you go, you're going to see tons of this used. And there's a lot of good applications for it. The resistance rates are relatively low, and it seems to be holding pretty steady. So we use it for a lot of different things. You can even cover some gram-negatives, like E. coli for urinary tract infections. Cephalexin actually works quite well for that, and it's got good susceptibility to that overall. Second generation, cefoxitin, cefatitin, cefuroxime. I don't care if you know cephalochlor or cefprozil, but the other ones should be able to recognize those as 2nd generation. So where do we use these? Well, cefoxitin and cefatitin have a bit of a unique area where they actually have activity against anaerobes that you might find in the GI tract, like Bacteroides. So these could be used post-intra-abdominal surgery as a prophylactic agent, or even for intra-abdominal infections. And they will cover not only your gram-negatives that you'd find in the GI tract, like E. coli, they're going to do a good job covering anaerobes too. So they're really one of the only cephalosporins that has pretty decent anaerobic coverage. So it's a bit stepping out of the norm with generations, because these have some extended coverage in the anaerobic realm that even some of the 4th generation cephalosporins don't really have that long. So it's worth remembering that. As far as cefuroxime goes, it's just going to be an advanced version of cephalexin or cefazolin. And so if you have somebody who's resistant to a 1st generation cephalosporin, a lot of times they might be susceptible to 2nd generation. So it's just going to pretty much extend the coverage of various gram-negative species and E. coli. So, situationally useful. I see cefuroxime as an oral agent used a lot for pyelonephritis and urinary tract infections. There's not a ton of evidence for that per se, but the coverage rates for E. coli for advanced generation, and by advanced I mean above first generation, are like 98%. So if you're going to prescribe something, you're pretty much guaranteed to cover it with this, assuming it's going to be E. coli and a UTI. But we'll get to those nuances next in the next set of slides for next week and talk a little bit more about UTI. So I'm getting ahead of myself a bit, but just to highlight where these are used. Yeah, other than that, just know that it's just more broad spectrum than the first generations. It doesn't really add anything different. Cefuroxime, that is. Third generations. So third generations are broken down into two different groups, IV. So you have groups that don't cover Pseudomonas, and then one drug that does cover Pseudomonas. So Pseudomonas is a resistant gram-negative. It's an opportunistic and pathogen. It has big association with healthcare exposure and immunocompromised patients. It's hard to treat, and a lot of drugs don't cover it. So if we have something that covers it, we want to remember that. The only other drug we talked about that covers it is Zosyn so far. I think that said that on there. And I'll show you a summary of that once we're done with the beta-lactam class. But ceftriaxone or Rocephin does not cover Pseudomonas. However, this is probably like the world's best antibiotic. It's pretty much a favorite for a lot of things. Anything from first-line therapy for meningitis, it's great for pneumonia, it's good for UTIs and pyelonephritis, it's got great tissue penetration, and it's not renally cleared. So that's a big winner in my book, because when you get as many elderly people and renal failure patients as I do in my hospital, it's nice to have a good weapon in your arsenal that's highly effective, well tolerated, and you don't have to worry about renal dosing. So it's pretty much hepatically metabolized, and those metabolites must get excreted in the bile or something. It's once daily dosed, which is another great option. So it is IV only. That's probably its biggest downfall. There's not a direct oral equivalent to ceftriaxone. Some people will use the second generation cefuroxime acetyl, so this drug here, down here, as a alternative. So they might start somebody on IV or IM ceftriaxone and convert them to this one. They aren't quite equivalent, but they have pretty close to the same coverage. Cefotaxime is very similar to ceftriaxone. It's got a shorter half-life. It's not once daily dosed. It is renally cleared. So why do we care? Well, it's more used in pediatric patients. Ceftriaxone has some biliary sludge buildup issues with peds patients, which we'll come back to during the peds lecture. But that's really the only area where cefotaxime takes it, is in really little kids, like neonates. And then ceftazidime is a third generation with activity against Pseudomonas. But the interesting thing is, it actually has poor gram-positive ability compared to ceftriaxone. So for like streptococcus coverage, it just doesn't cover them as well as something like ceftriaxone. So sure, you gain Pseudomonas coverage, which is nice, but you're losing some other things. So where we use ceftazidime is really as a silver bullet for a Pseudomonas infection that we know is sensitive to ceftazidime. And that's really the only place. We don't treat empirically with ceftazidime because it's variable coverage for other common bacteria. PO, third generation cephalosporins, there's no option for Pseudomonas. In fact, PO third gens tend to have just weaker coverage overall if you compare them directly to their IV counterparts. Why exactly? Not sure. They have similar structures. They, on paper, they look okay, but there's been some studies that show that for certain bacteria that, for example, Rocephin or ceftriaxone might cover, they just don't have good clinical evidence for their use. Again, I don't have a good explanation for that. But for the most part, you can consider them interchangeable, but know that there are some issues there. So specifically Pseudomonas, you would never want to convert somebody to a third generation cephalosporin for a Pseudomonas infection. You're not going to cover it. And there's some other things like Enterobacter that have some iffy coverage as well, but I'm not going to get into that right now. But these are good drugs for broad spectrum, like pulmonary infections, UTIs. They like to use these drugs a lot for the kids who have UTIs because they're going to cover pretty much any type of bacteria that can get to the urinary tract in kids. And then for like outpatient pneumonia, these are a good second option. So that's where we might see them used a little bit, but not a ton of use for the third gen cephalosporins in the PO form, that is. Fourth and fifth. So cefepime is another really great drug that we have. It's a broad spectrum cephalosporin, and it's the most broad spectrum one used in current practice. It's a pseudomonal agent, so it does cover Pseudomonas, and it has good gram-positive. So if you kind of combine ceftriaxone and ceftazidime and then add some more stuff to it, like even more broad spectrum coverage of gram-negatives, you're going to get cefepime. It's a really good broad negative empiric coverage agent, so we use this a lot for people who come into the hospital who look septic, we don't know the source. Cefepime is a good choice for that. It's not going to cover anaerobes, so intra-abdominal infections, you'd want to either add something to cover those anaerobes or switch them to something like Zosyn. And then it does have good central nervous system penetration, so you could use it for like a meningitis or something like that if you needed to. Ceftaroline is the newest generation anti-cephalosporin out. It's kind of in its own island. It's considered maybe a fourth or a fifth. At this point, like, who really cares? It's just an advanced generation cephalosporin, and you have the only cephalosporin here with methicillin-resistant Staph aureus coverage. So it does cover MRSA, but it loses a lot of other utility. So it's not like it's Cefepime plus MRSA coverage. It's MRSA coverage, but it doesn't really have like the Pseudomonas coverage. It's kind of got 4 gram-negative coverage overall, maybe middle of the road for a cephalosporin. It's used for maybe some skin and soft tissue infections here and there. We don't use it a whole lot at our institution, but it's kind of expensive too. And ceftobiprole is considered the true 5th generation. I won't test you on this agent, but it's considered like a magic drug that covers everything. It's actually been around in Europe for a while, and I think the reason it hasn't come over to the U.S. is because there's some sort of legal issue with the patent. Somebody owned the patent, and somebody else didn't think they should own it, and then they sued them, and so it's been tied up in litigation forever. But it's actually cephalosporin, kind of like Cefepime, but it does cover MRSA too. So it's one of the only drugs out there that would exist that not only covers MRSA, but covers really resistant gram-negative pathogens as well. So it could be sort of like a one-stop shop for empiric broad-spectrum therapy. We're now, with Cefepime or Zosyn, we have to combine it with something else like vancomycin to get the MRSA coverage added to it. And carbapenems. So carbapenems are our big guns. These are really broad spectrum. So think Cefepime, think Zosyn, but bigger. They cover anaerobes, so they all cover anaerobes. So you've got that intra-abdominal aspect covered with your carbapenems. And I like to think they're an alternative to Zosyn. So where do we use these? Well, would you use them empirically? The nice thing about carbapenems is that they have minimal cross-reactivity with other agents. If somebody has an allergy to cephalosporin or penicillins, the odds of them reacting to carbapenems are slim to none. So that's where we see these used a lot right off the bat. Otherwise, there's not a lot of uses for them. Not to say they aren't used. They're used probably way too much. So I think people like them because if you have somebody really sick and they aren't getting better, try carbapenem and see if maybe you're going to pick something else up that you aren't getting on the culture. But I think these are dangerous. So whenever you're going to think about prescribing a carbapenem, just because of the fact that these are really last-line therapy, we want to make sure we're using them very appropriately. So a couple different drugs. The first 3, Primaxin, or imipenem, meropenem, and doripenem, are all essentially interchangeable. They all do basically the same thing, cover the same group of bugs. Ertapenem is the oddball, and the only thing it doesn't do is cover Pseudomonas, so it's a little bit less broad spectrum. Ertapenem is super expensive. Generally, carbapenems in general are more expensive than anything else we've talked about, but ertapenem is quite a bit more expensive than any of the other ones. So what else is there? Meropenem has really good CNS penetration. Imipenem doesn't. So if you have a resistant pathogen in the central nervous system, you can't use imipenem. So where is that a problem? Well, like at our hospital, imipenem's our primary carbapenem we use. We don't stock a lot of the other ones, and it's the one we get most often. And if we run into the issue of a central nervous system, then we'd have to get meropenem or doripenem in specifically for that. But again, they're all pretty much interchangeable, and most hospitals will have one on formulary that you can order. And the rest of them you could get if you needed it, but it'd have to be a very special circumstance. Okay, I've talked about allergies a lot, but up to 10% of general population will report penicillin allergy. Studies will show it all over the place. So most studies will say that if you test all those that 10% of people, like 1% will actually react to it. So most people don't actually have penicillin allergies. So we don't know if it's to take them seriously or not, but if somebody's really concerned about it, they have a very convincing story that they had an allergic reaction, or they know for sure they had an anaphylactic response to something, then that might be a reason why not to prescribe them. Childhood reactions are debatable, like I said earlier. And then really consider immune-mediated versus what we call intolerance. So was it actually an immune system-related reaction, or did they just have some kind of a, intolerance, like a nausea or an episode of vomiting or something like that. We don't usually have the luxury to actually just sit there and test somebody to see if they'll respond to it, so we have to take people at their word, which isn't always the most convenient for us, but you don't want to put somebody into anaphylaxis when they're already critically ill, so we do try and err on the side of safety, and just some things to remember. So cross-reactivity, so let's say somebody has a penicillin allergy reported. A cephalosporin has about 2% cross-reactivity for a truly allergic patient. So that means that if somebody is for sure allergic to penicillin and give them a cephalosporin, about a 2% chance of causing a reaction. That's low. That's within the realm of acceptability. However, we take it one step further, and if they do have a history of anaphylaxis to penicillins, we will skip cephalosporins altogether and we'll go straight to carbapenems because the risk is extremely low. That's where it comes in handy, is to ask the patient, hey, have you ever been on something called Keflex? Have you ever been on cephalosporin? They might know. They might be able to tell you, oh, yeah, I took that. Or you might be able to look at that in a chart that they've had something like that in the past. It's always nice not to be the first provider to challenge somebody's allergy, right? Be like, oh, this person did it last time they were here. Perfect. That's what I like to see. You can do a graded challenge to people, which I've rarely ever seen done. There's some situations where this might be helpful, and I'll talk about that on the recorded lecture next week. But you would give 1/100th of the dose, then 1/10th of the dose, and if they didn't react, you can get the full dose after that. So again, I've never actually seen this done, but you could do it. You can also desensitize people by giving very small amounts over a period of time, which I'll talk about with we talk about syphilis, which is where we would do that in that case. But and then the last beta-lactam, and then we'll take a quick break, monobactam, is aztreonam. Aztreonam is a broad spectrum, kind of like a carbapenem, but you don't really have good anaerobic coverage. It does cover Pseudomonas. It's IV only, and it's only true alternative for a severely beta-lactam allergy patient that's still within the beta-lactam group, so to speak. So there's no risk of aztreonam cross-reacting. So this would be the case of a person who had a severe allergic reaction to a carbapenem. They'd be on aztreonam. That's really how you get here. So it's very rare to see this prescribed. It's restricted. It's super expensive, but it is an effective antibiotic. It has some side effects, some blood dyscrasia stuff. It can cause neutropenia, and it can elevate liver enzymes too. So it might look like the person has some transient liver failure, but they don't. It's just part of the drug. So, all right. And as far as spectrum review, we'll talk about the next group of drugs too, and cover this each time. But this is just a way to itemize them as far as different groups. Of course, these drugs have different coverages than those drugs that aren't on here. But if you're looking to break things down based on specific criteria, we have MRSA. So the only drug we talked about that covers that is ciftetraline. Pseudomonas, you've got a couple choices there. Anaerobes, you have some choices there. And nothing we've talked about covers atypical pathogens. Atypical pathogens are usually respiratory associated, and we'll talk about those in a second here when we talk about macrolide antibiotics. But we'll add some drugs to this as we go through. But this is basically how to frame very specific targeting of antibiotics. And if you know something covers Pseudomonas, that's another trigger. Oh, this is really broad spectrum. So it's not like it just covers Pseudomonas, it covers tons of stuff. MRSA is a little bit different. If you know it covers anaerobes, it's a good trigger that, okay, we're talking about intra-abdominal infections. Which drugs cover anaerobes? Oh, those ones do. So that's another way to remember those types of things. And I didn't put Unison or oops, I can't edit this here, but you would want to add ampicillin and the sulbactam and amoxicillin clavulanate onto the anaerobic coverage because they do cover that as well.
Say that again slower.
We can't spell
You read it on the board.
Okay. Unison and augmentin, which would be ampicillin. So the ampicillin drugs, ampicillin, amoxicillin, but it's got to be, they got to have the beta-lactamase inhibitors. Sorry, I'm writing kind of behind the board there. Plus, let's say BLI, which would be your brand names, Unison or Augmentin. So if you go back to the extended spectrum slide with Zilson on it, it's that same one, just the bullet point above it. All right. So let's take a 5-minute break and come back and do the rest of these drugs. a sheet of pictures that's at home. I keep forgetting it, but just so I can start to pick up a couple names here and there. Okay.
Can I just ask a question?
Yes.
The beta.
What's your name?
So your name for.
Paige. Yes, Paige.
So the beta inhibitors, is that like just beta inhibitors? There's no special name for it, but that can be added to anything.
Beta-lactamase inhibitors can be added to. So that's a good question. I didn't include. There's some newer ones that are out. Some carbapenemase inhibitor, or not carbapenemase inhibitors. Cephalosporinase inhibitors that are out they're combining some of the advanced generation cephalosporins now with specific cephalosporinase inhibitors, kind of like they're doing with Augmentin or Zosyn. But so yeah, theoretically you could, if you could make the drug that way. Maybe that's a future area of investigation for like a carbapenem, is making a carbapenemase inhibitor to add to it to couple some of those really nasty superbugs coming over. But yeah, you can't really add it to anything, and I think they still have to be stable together, and it has to be targeted towards that specific drug's, the specific mechanism the bacteria is using. So you have to figure out what enzyme the bacteria is producing that's degrading your drug, and then build a drug that combats that. So that can take a while to figure out. So it might not be easy, and it might even not be possible. But we're seeing some of that combination with cephalosporins. However, they aren't seeing a great clinical use for those. So that's why I don't include them, because they really aren't being used at all, but they're brand new drugs. All right. All right, some other gram-positive cell wall agents. Vancomycin is a glycopeptide. It's a powerful gram-positive agent, and I think vancomycin gets mistaken as a broad-spectrum antibiotic. It's not. It's actually pretty narrow spectrum. The only thing we really use it for is MRSA coverage, and that's it. It would cover other gram-positive too, so it has some streptococcus activity, but for the most part, it's a MRSA silver bullet, and that's what we use it for. And once we can prove somebody doesn't have MRSA, we get rid of vanco really fast. So when you have somebody who comes into the hospital really sick, we cover for MRSA empirically, and as soon as the culture comes back negative, it's gone. We don't keep it on for any reason, unless there's a suspected history and we aren't culturing it well, or the culture didn't go through or something like that. It does come IV and oral, and here's an important distinction point. IV vancomycin and oral vancomycin do not have the same indications, and you can't cross them over. So vancomycin is a big molecule. I put it up there just to highlight that it's giant compared to like a beta-lactam. It doesn't absorb through the GI tract very well at all. You get a little bit, but not enough to be clinically significant. And it also doesn't really penetrate the GI tract when given intravenously. So we actually use vanco orally, but we use it for C. difficile infection. So we use it as basically a topical agent in the GI tract itself. It doesn't leave there. It gets flushed through, and we'll talk about that during C. diff. But if you ever see oral vanco versus IV vanco, it's just an important distinction point that they have very different indications. Vanco is historically something that pharmacy doses. This came about years and years ago when pharmacists were trying to prove their worth in the clinical setting. So we're like, hey, how about we take blood concentrations on these patients and prove that we're in the right, we're getting the right target concentrations that we want to see. And so we still actually do that today. And what we're really looking pretty much at is trough levels. So we want to see when this drug concentration drops before we give the next dose, what's it at, and is it getting too low? So we target a certain trough concentration with vanco. That's really all there is to it. Of course, we're watching to make sure that the patient isn't accumulating a ton of it. Like, it's kind of nice, so if you start somebody on vancomycin and all of a sudden they develop an acute kidney injury, you can do a level on them to see how high it is, and then you can say, all right, well, they don't need a dose for a few days because their kidneys don't work, and just let their body kind of take it down naturally. It's a common thing. So if you ever see like a pharmacy to dose kinetics profile or protocol, or pharmacy to dose vanco or aminoglycoside protocol, that's what this is, and that's what you feel free to order that if you work in the hospital setting, and like the pharmacy team work on that for you, because we'll do all the dosing, we'll do all the follow-up and monitoring. You can certainly check in on us and see how it's going, but we'll put notes in and stuff like that too. So it's just sort of a unique thing with antibiotics. There's not a lot that we manage anymore, but that is one thing we do. Vanco has some controversial side effects. Some people think it's oto and renally toxic at high doses. And when I say some people think, it hasn't been very well proven that it is actually renally toxic. There's some debate over whether or not a high dose of vancomycin as far as like if you looked at clinical evidence for it, you see a trial that says, well, all these people had elevated serum creatinine and they also had elevated vancomycin levels. Which came first? Were they on vancomycin previously? How do we know the vanco caused that? Was there a confounding variable? Was there another drug that's nephrotoxic on it? Vancomycin itself is thought to be probably nephrotoxic, but we don't know that for sure. So it's just something I'll throw out there that it may or may not be nephrotoxic, but it's not like a guaranteed nephrotoxic. It may be also ototoxic. So at really high doses, you can get tinnitus and other issues with ear-related problems, but that has to get quite high. So really what we're worried about with high doses of vancomycin is that nephrotoxicity. But again, it happens all the time where you get somebody who's just a really poor eliminator, or somebody who just doesn't, or either goes through like an acute kidney failure right away. Maybe they come in septic and everything's still working, and that sepsis turns into a severe septic shock, and their kidneys go out, and they've got a whole bunch of vanco in their tank that their body can't eliminate at that point. So vanco is primarily renally eliminated. It's not really hepatically metabolized all that much. It just gets filtered out over time. So there's some things to consider with the side effects of it. Otherwise, it's a pretty well tolerated thing. I didn't put this on the slide, but I'm remembering to say it this year, which I'm happy about. Red man syndrome is something that happens with vancomycin, and it's sort of an allergic reaction type thing. It's relatively common. You'll probably see it in your careers if you work in hospital medicine. And it's people get flushed in their upper extremities, neck, and face. It's not anaphylaxis. And in fact, you can just stop the infusion of vanco and start it at like half the rate it's going. That usually resolves the problem. You don't have to discontinue the drug altogether. You can give some Benadryl too, or diphenhydramine antihistamine to prevent that reaction or help the reactions and symptoms subside a little bit. But for the most part, it's not an intolerance or a contraindication to giving it again. There are patients who get really bad red man and they won't tolerate it at all, but most patients you can get by with it. Yeah.
Did you say that's usually just the upper extremities?
Upper extremities, yeah. Kind of trunk, arms, sometimes neck and face too. Daptomycin. So what happens if you're really allergic to vancomycin? Well, you give daptomycin. Or if you're resistant to vancomycin, you give daptomycin. Dapto's the next thing in line when it comes to advanced gram-positive infections. So it treats pretty much the same group of things we use for vancomycin. There's something called VRE, which is vancomycin-resistant enterococcus, and that's it can be associated with things like urinary tract infections and urine sepsis potentially. It's rarely like a bloodstream infection, but that's possible. For the most part, VRE is one of the more common vancomycin-resistant organisms we're going to see. Vancomycin-resistant Staph aureus is extremely rare. In fact, there's only been a handful of cases in the last 10 years in Minnesota with it. So to see that is almost impossible. So that's why we like vanco for Staph aureus. Unless you have a really good reason to use daptomycin. Dapto is about 10 times the cost of vanco. So I know there's one time where an IV provider I think came in and talked to a group of a previous class, and then the students were like, Chad, why don't you like vanco? Well, it's super expensive, that's why. It's like $1,000 per dose. So if you don't have to use it, you shouldn't be using it just because it's a huge cost on the patient and on the health system. And in most cases, you don't need it. Dapto also doesn't work for central nervous system infections, and vanco is a first-line therapy for meningitis, so that wouldn't be a good alternative. We also use vanco for MRSA pneumonias, and you can't use dapto for pulmonary infections either, because the pulmonary surfactant will actually denature the daptomycin molecule. So you could use it for bloodstream infection, you could use it for other things, potentially like urosepsis, but it does have limited role. And there's another drug that we can use in alternative to vanco that I'll talk about is more important. I didn't highlight or bold any of the other ones on the slide because I don't care that you actually know them. I'm not going to test you on them. Telavancin and dalavancin are alternatives. They're similar to what we just talked about with dapto. Super expensive, different side effect profiles, and really not used all that often. It'd be a really odd case where you'd need one of these drugs. It's a super resistant pathogen with weird sensitivities or very odd allergies or intolerances to the patient. Oritavancin is kind of cool. I'm not going to test you on this, but I'll just mention it. It's this new drug that's a single dose, so it's got a 245-hour half-life for $1,200, which sounds like a lot of money. But the idea behind this is, let's say you come in and you have a MRSA infection, and you've tried some outpatient therapies, or maybe it's resistant to anything oral that covers MRSA. So you want something IV, you want vancomycin, but you don't want the patient to be in the hospital for 5-10 days because they need IV antibiotics, so you don't want to have them come back to an infusion center every day for that. It's a lot of work, it's a lot of extra cost. So you give them a $1,200 injection one time. This drug actually is designed for this exact situation. It's supposed to be done in like a clinic setting, and the billing and reimbursement is going to be sketchy. So whether the insurance will pay for it or not is a great debate. We haven't really embraced it yet, even though I think there is some pretty good utility for it. I could see it being really advantageous for those patients who are in that situation, because it does happen where people are coming to infusion centers twice a day to get their vancomycin dose. So obviously not convenient, whereas something like this would be really nice. But you might see patients just say, hey, I'll pay the $1,200 out of pocket so I don't have to do that. Yeah.
You should be concerned with allergies for long half-life drugs.
Mm-hmm. But these drugs, well, that's the thing. These drugs aren't used all that often, but I don't think there's a huge amount of reactivity to it. So I don't know what they would do. That's a great question. If you gave this to somebody, the odds of them ever having experienced telavancin or dalbavancin would be pretty much 0% chance. So yeah, you are taking a bit of a gamble with that, but the risk would be pretty low. I don't know if they do a test dose or anything like that. I haven't heard of that, but yeah, interesting. Okay, so we just added a couple things for test purposes, Vanco and Dapto and the rest of the drugs I won't ask you about for that section. Protein synthesis inhibitors. Protein synthesis inhibitors generally target gram-negative bacteria, and they're binding to different portions of the different subunits in the ribosome intracellularly, and they're disrupting messenger RNA processing. And different drugs will bind to different sections. It doesn't really matter. They all kind of do the same thing. But they're here in case you're curious or want to look into that. Tetracyclines are mostly bacteriostatic, with the exception of one advanced tetracycline called tigacycline. They do cover MRSA, so there's another MRSA covering agent, and they do have a really interesting spectrum of activity generally. Some things we don't like to use tetracyclines for: children younger than 8. They can stain teeth, which is a cosmetic thing. It doesn't like kill the tooth off. And there's some debate over whether that actually happens or not. And generally, we avoid them in pregnancy, too. But other than that, they have some interesting infectious disease benefits that we'll talk about during specific treatments, like Lyme disease, for example. Tetracycline by itself as a drug isn't really used all that much. It's got really bad GI side effects. It does QID. It's renally adjusted. None of those things we like, so we don't use it. There's really no purpose to it anymore. Monocycline is minocin, or minocin, however you pronounce it, and it's a PO tetracycline. It's sometimes used for other things, but it's pretty much primarily an acne medication. And we'll talk about acne during derm specifically, and the antibiotics and topical antibiotics used for that. So we'll come back to that in the winter. Doxycycline is IV and PO medication, and doxy I like because it covers a lot of weird stuff. So if you're ever like, what should I use? This person has a lot of allergies. This person has a weird organism. Will doxy cover this? And sometimes, the answer is yes. And it's a nice thing to keep in your back pocket as a potential alternative for a lot of things. And specifically for people with weird allergies to lots of common antibiotics, they probably aren't going to have a tetracycline allergy. It's not common, so it could be a good option to try. Good gram-positive and negative. We use it for Lyme's disease, anthrax, plague, malaria, other unusual diseases, so pretty much all the weird stuff. This is one of the drugs the CDC keeps stockpiles of in case there's a biochemical warfare attack, like an anthrax attack. We used to have some in my office at work, but it all expired, so I guess we're out of luck there. Skin, pulmonary, urinary, CNS infections gets pretty much everywhere in the body, so we can use it for a lot of different stuff. And besides the weird things, it covers standard things like Streptococcus pneumoniae for pneumonia. It covers it does have some MRSA covers like we talked about before, so you can use it for skin and soft tissue infections. So it does have a lot of nice advantages there. Tigacycline, I'm not going to test you on. It's really broad spectrum. No one uses it anymore very often. It's super expensive, and it does have this weird black box warning the FDA put on it because there was some post-marketing data that showed that it increased overall mortality risk by a very small amount, 0.6%. It'd be sort of an end-of-the-line therapy if you ever used it. But it is a broad-spectrum agent. Covers all resistant gram-positives, covers resistant gram-negatives, with the exception of Pseudomonas. And it does cover anaerobes, too, so there's some different stuff you could use it for. But, again, not very commonly used. Macrolides are a class that mostly cover gram-negative and have atypical coverage. Erythromycin is the older macrolide, and clarithromycin. Clarithromycin is part of a regimen on the next set, so that should probably be bolded. So keep that in mind as a macrolide. I won't ask you about erythromycin. Azithromycin is the common one. It's used mostly for ENT indications, and it's probably the most inappropriately prescribed antibiotic on the planet. I kind of hate azithromycin, although there are some good uses for it, and we'll talk about those. But its strep pneumococcus coverage is really weak, and that's its biggest problem. So we just don't have a good option for it for a lower respiratory tract infection, and it just shouldn't be used for pneumonia ever by itself. So it does cover atypical organisms quite well. So if you're going to use it for pneumonia, you have to add something on. So oftentimes we'll add like a cephalosporin to this. So something like a 3rd generation cephalosporin would be a good combination with azithromycin for pneumonia. And we'll talk about that during the next series of slides. But the point is that there's some limited use for this. And I think people like prescribing it because it's a Z-Pack, it's nice and easy to write. Z-Pack on your prescription, and take it in or type it into the computer, and it populates all the doses and everything for you. But it's not often appropriate. I think there's very few instances where it's actually useful, and we'll talk about those specifically. But if you're ever prescribing azithromycin for somebody, that should trigger a red flag in your mind. Why are you doing that? Double check and make sure you're actually doing the right thing here, because it doesn't really cover all that much stuff that's useful. There's some utility to it, but just be careful with it.
So what would you personally diagnose for now?
I'll talk about that during the next series. I don't want to get too far ahead of myself, but it does have some utility in pneumonia, but again, in combination. It has some prophylactic indications. There are some other uses for it too, but yeah. Aminoglycosides, I'm not going to spend a lot of time on. These used to be really popular, broad-spectrum gram-negative agents, but now that we have drugs like cefepime and piperacillin and carbapenems, they've taken the place of these. Because they're much better tolerated, you don't have to monitor for them. These drugs are really toxic. These are actually pretty renally toxic. If you're on aminoglycoside for more than 7 days, the odds are good you're going to get some form of acute kidney injury, even if you're healthy. So it's not the best situation. They use it a lot still in OB, but they're using them in very small intervals. They might do like if you have endometritis, which is like a elevation in temperature diagnosis. Right after right after you give birth, they might give you like 1 dose for 24 hours until your fever is normal. Very rarely are you seeing continued doses. So it's really one of the only areas we still see it used. You could pull this out. These drugs do cover Pseudomonas. So for problematic infections like requiring more creative treatment, so either because the person's allergic to things or there's a lot of resistance, every once in a while you might have to pull one of these out of your back pocket, especially if you end up working in critical care. You're probably going to see, like if you work in a neuromed ICU, you will see these used occasionally. But for the majority of patients, we stay away from them just because of their therapeutic index isn't great, and the renal toxicity is bad. Clindamycin, or mostly called Clinda by people, is PO and IV. There's no renal adjustment available, so keep that one in mind. So the only real two we've talked about with no renal adjustment are clindamycin and ceftriaxone. So those are pretty much the two. Azithromycin also doesn't have any, so there's 3 there. Really, I think there might be one more we talk about too, but it's not many, like I promised. Maybe bacteriostatic or bactericidal, we don't really care, it doesn't matter. It works, good gram-positive and anaerobic coverage, poor gram-negative coverage. So it's kind of an interesting drug where it can cover actually MRSA to a certain degree, but it really has very little gram-negative coverage. But it does cover GI pathogens. Where it's used a lot is an alternative for skin and soft tissue infections. Most people aren't allergic to clindamycin. So if you're allergic to like cephalexin, or a cephalosporin allergy, this is a great alternative for these patients. They use it a lot for oral surgeries because it covers anaerobes that would be present in the mouth, covers other types of bugs that you would find in the mouth too. It doesn't really work great for intra-abdominal infections, so I always think of Clinda's anaerobic coverage coming with the caveat that it's sort of like, the respiratory tract and above, not really belly anaerobes, which would be a different set of medications. Linezolid is the other alternative to vancomycin I want you to know. So we have daptomycin and then linezolid are pretty much the two we're going to see for either vancomycin resistance or allergies. Linezolid's bacteriostatic, so it's a slower killing agent. It does come IV and PO, so it's got a nice transition potential. So if you have somebody on linezolid, you can transition them to outpatient therapy really easily. And it used to be really expensive. However, I think the IV form is actually quite expensive still, but the oral went generic recently, and it like went from like one of the most expensive drugs in the world, like $100 a pill, to nothing. And it's like, you know, pennies a pill. So how it went from such an extreme, I don't know, but we'll take it. So this one is actually a good option for an alternative if you're looking to treat somebody outpatient for